My name is Ahmed Amro. I'm a second-year general cardiology fellow at Marshall University. I have no disclosures. So my presentation will be retrograde pedal access as bailout procedure for endovascular intervention complications. Our patient is a 76-year-old female patient with history of diabetes, hypertension, CAD, and smoking. She presented complaining of intermittent severe claudication in her left leg with a Rutherford classification of 3. Her left leg ABI was 0.61. Pre-intervention angiogram showed totally occluded mid-SFA that reconstitute at the distal SFA, which was patent, as shown here in this image. While trying to cross the totally occluded mid-SFA using the conventional CFA axis, perforation developed just exactly at the edge of the lesion, as shown here, just exactly at the edge. So the wire was exchanged with a glide wire gold in an attempt to cross the lesion, which was unsuccessful. So the catheter was removed and ever-cross balloon was inflated at 2 atmosphere proximal to the lesion in an attempt to tamponade the bleeding. Access then was obtained through the left posterior tibial artery using an ultrasound, and a 6 French glide sheath was inserted that was followed by the antispasmodic cocktail. Then a glide tip wire was inserted through the pedal sheath along with Navicross catheter that was successful in crossing the totally occluded mid-SFA. After the catheter was removed, Everflex self-expanding stent was inserted and deployed in the mid-SFA. So in this case, coming retrogradely, created a flap that sealed the perforation without the need to use a covered stent. Angiogram revealed like resolution of the perforation as shown here. So to minimize the risk of access vessel thrombosis, the pedal sheath and deployed mid-system were then removed as soon as the stent was deployed. Hemostasis was achieved by holding pressure for 10 minutes. So in this case, a quick pedal access was safe, practical, and timely critical in managing SFA perforation while maintaining balloon tamponade above the lesion. Hence, traditional tamponade across the lesion in this case was not possible due to the site of perforation, which was exactly at the edge of the lesion. Another point to bring here is that retrograde access allowed us to create a retrograde flap, which completely sealed the perforation without the need to use cover stent. Two important factors for successful retrograde pedal approach here are adequate knowledge and training, as it is an evolving approach, and attaining duplex ultrasound knowledge and interpretation is crucial here. So as a home point, retrograde pedal access is safe and effective approach for delivery of stents from distal approach and can be used as bailout technique for SFA perforation. And physicians or interventionists involved in peripheral intervention will require having a full understanding of this approach and acquiring the necessary skills to perform it safely and effectively to be able to finish what they started. Thank you.
I think, especially in light of all the cases we saw today, this is a very good case. Again, discussing what to do when using the pedal approach, particularly here as a bailout. Do you think that, first of all, did the patient have any symptoms, whatever? How much bleeding do you think there was, and was the balloon? How important was that balloon tamponade from the antegrade approach?
It was bleeding quite significant, as shown on the angiogram. So, I mean, we could not just let it go, especially we could not tamponade it. It was just exactly at the edge, like you could not cross the wire and to like tamponade that bleeding. There was no way to stop that bleeding. And it was not side branch, it was the SFA.
Good case again. What is the mechanism again? This was a wire perf, right?
So it was wire perf, just like where's the cab of the CTO. So the wire just passed beside it and created a flap. So it was just perf, actual perf, but it was not just like before it or after we crossed the cab. We did not even cross. It was just at the edge.
Because usually wire perfs are managed very conservatively. You don't, you do a balloon tamponade, prolonged balloon tamponade, and most of those are self-limiting.
Mm-hmm.
So, okay.
Yeah, one of the challenges with these CTOs is the collaterals that come off can sometimes be the actual source of perforation, and just by ballooning the main vessel you don't necessarily exclude the bleeding from that daughter vessel through retrograde perfusion. It can still be an issue.
Also, the retrograde here was to cross the region also, because you cannot even try to cross the region while there is perf. Even if we tamponaded and stopped that bleeding, then we have to leave that lesion. But coming from below, we treated the lesion and we treated the perf at the same time, and we did not even have to use a covered stent. We just used like self-expandable stent because we sealed the flap.
Great. Well, thank you very much.
Thank you.
Thank you for everybody's attention for this session, and that'll conclude.